Good evening, everyone. We are so thankful to have you all with us today for our second panel discussion. This evening, we're going to focus on meeting the unmet need, an informative discussion about testing, coaching, and your continuum of care. My name is Dr. Arnethia Sutton. I am one of the proud members of the Medical Advisory Board for the Chrysalis Initiative. And it is my pleasure today to introduce the moderator for our panel, Jamil Rivers. What can I say about Jamil? Jamil is a wife, a caregiver, a mother of 3 sons. She's a survivor, a fighter, a thriver. She was diagnosed with stage 4 de novo metastatic breast cancer in 2018. She is a leader, an agent of change. Jamil is the founder and CEO of the Chrysalis Initiative, board president of Mediviver Research and Support, Inc., and a member and patient advisor of the Metastatic Breast Cancer Alliance, just to name a few. Lastly, for those of us who know Jamil, and for those of you who will meet her today, you will recognize Jamil's palpable passion for equity and advocacy. She walks the talk, and because of that, many lives have been changed and even prolonged. Again, I will say, it is my pleasure to introduce to you Jamil Rivers. Jamil?
Hi. Thank you so much. I'm so tickled. Thank you so much. Thank you for everyone joining us this evening for the second webinar panel for our breast cancer education series, Meeting the Unmet Need. We have a fabulous dynamic panel today. And really, the whole point of this discussion this evening is to talk about our position with the Chrysalis Initiative is that if Black women with metastatic breast cancer and breast cancer receive standard of care, if we can ensure that, then we're going to eradicate and address some of these disparities that are related to bias and racism, and also resolving those barriers that come into play. If we can just ensure and have more accountability when it comes to standard of care, then we can reduce these disparities. And we're finding with our intervention that does occur. But we also need to understand that there are so many new innovations, therapeutics, imaging, diagnostics that we need to stay on top of. And so part of our care tracking is to also encourage outside of the coaching, but advocacy, so that we can really have ownership and empowerment living with this disease, being breast cancer survivors and thrivers, and know specifically what we need to know about the latest and greatest in the research and innovation that's out there, and making sure that we have support from organizations like the Chrysalis Initiative to access these therapeutics and diagnostics. So I would like to introduce our panel, and our first panelist is Dr. Lisa Newman. She is an internationally renowned breast surgeon and researcher. She was appointed chief of the section of breast surgery at New York Presbyterian Weill Cornell Medical Center and Weill Cornell Medicine, where she was recruited as the professor of surgery in August 2018. At the New York Presbyterian David H. Koch Center, Dr. Newman leads a multidisciplinary breast oncology program dedicated to providing individualized cutting-edge care. She also supervises the breast surgical oncology program at New York Presbyterian Lower Manhattan Hospital, New York Presbyterian Brooklyn Methodist Hospital, and New York Presbyterian Queens. She is the founding medical director for the International Center for the Study of Breast Cancer Subtypes, now part of Weill Cornell Medicine and New York Presbyterian. She also oversees an international breast cancer research and training program based at Weill Cornell Medicine, which involves a network of physicians and facilities in Ghana, Ethiopia, Nigeria, Uganda, Canada, and the Caribbean islands. And Dr. Newman has been an expert advisor to various associations and is currently an advisory board member for the Susan G. Komen Breast Cancer Foundation. And we also have our fabulous patient advocate and living with MBC, and she's also a Chrysalis Initiative participant. Shante Drakeford is a 36-year-old Washington, D.C. native. She is a nurse practitioner, Army wife, farmer, German Shepherd mama, and a friend to all. Shante was diagnosed with stage 4 metastatic breast cancer in 2015 at the age of 31 as her initial diagnosis. The cancer has metastasized to her lungs, hip, rib, spine, and lymph nodes. She also has a genetic mutation for colon cancer. She is triple positive, meaning the cancer grows from estrogen, progesterone, and the HER2 receptor. She started cancer detection early at the age of 25, but unfortunately was denied and delayed early detection diagnostics for 6 years before being diagnosed. Shantae continues to educate and advocate using the most evidence-based research of metastatic breast cancer care, and she has partnered with organizations, too many to name, including the Chrysalis Initiative. And so we are also going to be joined by Dr. Hope Rugo. I know she is in clinic today, and she will join as soon as she possibly can. But she is a hematologist and oncologist who specializes in breast cancer treatment. She joined the UCSF Carol Frank Buck Breast Cancer Care Center after a decade at UCSF Medical Center, where she worked in bone marrow transplantation for a variety of diseases, including breast cancer. Dr. Rugo is co-director of UCSF's Breast Cancer Clinical Trials Program. She is the principal investigator for several clinical trials of potential new therapies. She is also an investigator with the Bay Area's Specialized Programs of Research Excellence on Breast Cancer. The National Cancer Institute established SPORE to foster collaborative interdisciplinary cancer research. Hi, Dr. Rugo. I was just introducing you.
I've been on since the beginning.
Okay, great. All righty, so let's get right into it. Dr. Rugo, I hope you don't mind, but my first question is for you. I know that you are on the cutting edge of all of the research pertaining to metastatic breast cancer. Can you talk about some of the recent developments and innovation that you're excited about, especially with San Antonio Breast Cancer Symposium coming up in regards to metastatic breast cancer, in particular imaging and monitoring?
I'm sorry, maybe you could just mention that again. You want me to talk about imaging and monitoring for metastatic breast cancer?
Well, not necessarily just monitoring and imaging, but just some of the most recent innovations and research that you're excited about when it comes to MBC.
So, I think, metastatic breast cancer is obviously, and I don't know, for some reason, the background is very bizarre here, so apologize for that. But the, metastatic breast cancer is so complicated a question because it's really, multiple diseases. And certainly these are cancers that have metastasized outside of the breast and draining lymph nodes, generally the axilla, the internal mammary nodes, and to some degree, supraclavicular nodes are the nodes in the above the clavicle. But then after that, there are so many varieties of metastatic breast cancer. We've divided them into, hormone receptor negative, HER2 negative, HER2 positive, and then that's divided by hormone receptors, and then hormone receptor positive, HER2 negative, right? So, the sort of triple negative, HER2 positive, hormone receptor positive, HER2 positive, hormone receptor negative, and triple negative, I think, and you within those subtypes, there are huge differentials. And we're learning a lot more about those really all the time and trying to understand the differences that biology that you start with makes in terms of responses to different types of treatment, what the cancer does, how it behaves, where it goes, how you respond to therapies. But also we're trying to understand, I think, the natural history of cancer starting from early stage setting, based on these different subtypes. So for example, most triple negative cancers, particularly in young women, behave a certain way, but there's a subset of triple negative cancers that are very slow growing and respond differently and have different biomarkers. Hormone receptor positive disease generally is responsive to hormone therapy, but there's also a subset of those cancers that doesn't respond well to hormone therapy, and where we are really looking for alternative treatments. And within even the hormone responsive disease, there are different biomarkers that help us treat those cancers. Now, for HER2 positive disease, most HER2 positive cancers respond really well to HER2 targeted therapies, for which there are more and more that are incredibly effective. But there is a subset also that have very resistant disease, where we're trying to better understand treatment. So I think that just says that, it's hard to say what are the advances we've made in metastatic cancer because it's so heterogeneous. But within that question, I think that there are several areas where we've made huge progress. So, and you can really group them into three main categories. So antibody drug conjugates, a new way to deliver chemotherapy using antibodies that can bring the cancer target, the cancer payload. We think of chemotherapy as being toxin that's delivered to all sorts of cells and kills them. But really what we've always wanted to do is to bring those toxins more selectively to the cancer cell. So antibody drug conjugates are giving us a new way to deliver the toxins directly, or at least more closely, to the tumor cell. And one of the really cool things about the new generation of these antibody drug conjugates is that the payload, which is attached to the antibody, right? You got all these little payloads stuck off. We have those payload, so that really potent cancer drug is water soluble, so it can have a bystander effect. So it is delivered to the cell that has the protein that the antibody targets. But then when the cancer cell dies, or even just releases the toxin, it can leak out of the cancer cell and kill nearby cells. And so you would worry that that would cause a lot of death of good cells. But actually, one of the hallmarks of cancer is that the cells really like to stick together. They like to hang out in groups. So that means that you could really effectively kill cells even that don't have the protein that your antibody is targeting. So antibody drug conjugate is a very cool new drug, and seems like much more effective than naked chemotherapy. And we're hoping to see this move to earlier lines of treatment in the metastatic setting, as well as early stage disease. And for non-HER2 positive breast cancer, we already have 2 antibody drug conjugates that have improved survival. We used to think that improving survival was only for HER2 positive disease, but now we see for triple negative disease, hormone receptor positive disease, also we can improve survival with better treatments. The second area where we've made big progress is in hormone receptor positive disease. We have new targeted agents that improve survival. We have more targeted agents that have better toxicity profiles and seem to also work. Really exciting area, which is rapidly progressing. We have new hormone therapies that may be able to overcome resistance. So a lot of exciting areas, which are just already some in practice, making a huge difference, the CDK4/6 inhibitors, but new agents, even in press releases, not yet presented with data we're really excited about. So that's another area where we've made big improvements. And then the third area is with immunotherapy, where we have immunotherapy that can be used to improve survival for triple negative disease, but only a subset of triple negative disease. And if you figure triple negative breast cancer is about right now 15% or so of metastatic breast cancer, and only 40, maybe 35% of those patients will be eligible for immunotherapy. So obviously a big unmet need is expanding the patients who can benefit from immunotherapy. So there's a number of different studies that are looking at this in triple negative disease, HER2 positive disease, and more faster growing hormone resistant, hormone receptor positive disease. So those are the 3 big therapeutic improvements. But I think in addition to that, one of the things that's really important is this started out called the Patient-Centered Dosing Initiative, and really started by an advocate, and got together a group of advocates and researchers and clinicians. And there's actually even now a published paper based on the surveys that were done. And it was an oral presentation at our big meetings. And then the FDA actually took notice of this and started a really interesting initiative to try and improve dosing, so that we're not just looking at the maximum tolerated dose, but maybe effective doses that have reduced toxicity. So that's an area of great interest of mine, not just even the dosing, but also understanding toxicity and managing it proactively, so that we're not dealing with toxicity in the back door, but in the front door.
Right. Well, that is all really, really exciting. And I love your presentations in order for us to stay on top of the latest and greatest, and especially to follow these therapies and how they can benefit us personally. Can you also talk about when a person is initially diagnosed with metastatic breast cancer, what is, in order to determine what the best treatment recommendation is for that particular patient, what tests need to be initially presented, in addition to just imaging, what needs to be included that is not already incorporated in standard of care right now? So how do patients know that they should be advocating for themselves in order to make sure that they are being considered for these new therapies?
Such a great question, because what standard of care is in some ways open to interpretation. I just have done a few consults recently where, the standard of care for what these very great oncologists who I know thought was standard of care was not what we think is standard of care. So I think, it's open to interpretation. I had a couple of cases recently. Now they turned out to be early stage breast cancer, but for example, one woman presented with very locally advanced, coincidentally HER2 positive disease, and in her early 40s, and had an initial CT that showed a lytic lesion in a one area of her spine. So they thought that it was metastatic disease, and they were going to just go ahead and start as metastatic disease. But we said, look, the differential between understanding if this is metastatic cancer or not is so critical to everything about this patient. And so you need to do a biopsy. So is it an HMO? So we hadn't seen the patient yet, although now she's getting treatment with us. But so they did a biopsy, which came back benign. So then I said, well, you need to do two other tests, PET CT to see whether or not this is biologically active area, and an MRI to really look at what's going on in the spine. But the group didn't really feel like that was needed. So she actually waited about 2 weeks, changed her insurance, came to us. And what's remarkable is that neither of those studies showed anything that was consistent with metastatic disease. So we were able to rule out metastases in her case by just really being aggressive and getting all these tests done. So I think, there's so much fear and anxiety when you get diagnosed. You really have to be careful to, consult people and talk about, has the full workup being done without, you don't want to wait a really long time, but also, it's really rare where treatment needs to happen, like before you take your next breath. You have time to do the right thing in the majority of situations. So, there's a situation where you don't have as much time, and we call it immediately life-threatening disease. So for example, you're having trouble breathing, or your liver function tests are very abnormal. These are situations where you have terrible pain. You really do have to start something right away. But in most cases, if a patient has metastatic disease, we really encourage a biopsy of whatever is available to be biopsied, because we want to understand if there's any change in the biologic markers that drive treatment. So that's really important, because we're now seeing cancers that were hormone receptor positive and are negative. We're also seeing cancers that were thought to be HER2 positive and aren't, or were not HER2 positive, but really are. I mean, we see all of that. And so these are, critical for understanding the cancer. And then we need to understand, when we're getting biopsies, there are situations where it's really hard to get tumor that we can interpret. So, if you get a biopsy of the spine, for example, or a bone, and it's decalcified to remove the calcium, it can strip all the receptors. So I've had a few situations where patients had a bone biopsy and it was read as hormone receptor negative, but it looked and smelled and felt like hormone receptor positive disease. And these patients, then one patient I'm treating now is 81, I think. She's been on hormone therapy with a CDK4/6 inhibitor for, it will be 2 years in December, and her tumor was ER negative on her bone biopsy. So I think, it's like you have to balance and be cautious in interpretation and have somebody who can help with that. But a biopsy is really critical. Having imaging that where you really understand where your cancer is, so that you know how to evaluate it, that's really important too. And then exploring any clinical trials that you might be eligible for. So for example, for hormone receptor positive disease, there are a lot of trials looking at different targeted agents and hormone therapies. And a lot of people will get what's called next generation sequencing and look at the mutations, either by doing a tumor biopsy or by looking in blood right away. But actually, unless it's needed for a trial, we have a pretty standard approach in the first line setting. So I tend not to get that data until somebody needs to be close to making decisions about the next treatment, because it costs a lot of money. And if you have a big share of cost, you're paying the money right up front, and then you got to do it all over again, because we see acquired mutations with treatment. And so let's say you go on your hormone therapy and your ribociclib or wherever you're getting, and then 4 years later your cancer is growing. You have to do all those testing all over again, because nothing,
Right.
most of what you get in the beginning isn't valid. So, but for and for HER2 positive disease, we know what we're going to do. We don't need next generation sequencing. But for triple negative disease, we want to know if the tumor has an immune marker called PD-L1. And that's incredibly important. And it doesn't matter there if you can't get your tumor biopsy done right away, or you don't get enough tumor, you can send the tumor that you had from the early stage setting for testing too. You just need that PD-L1 testing back using something called the combined positive score in the United States, because that determines whether you can receive immunotherapy. So it's a really, really important step in determining your next treatment. So those are kind of the important things as you're moving forward. I think it's really useful to understand whether or not there's a clinical trial that might be beneficial for you, because a lot of times some of the really great trials you might want to participate in might require no prior treatment for metastatic disease. Some of them allow only 1 or 2 lines of treatment for metastatic disease. So you just want to know your options at every step of the way. And there actually are some clinical trial engines that you can put information in and know what you might be eligible for. Something called bct.org, for example. It's not perfect, but it actually can give you a steer right away in your area, what's available to you, what you can do to find out about it. Trying to get a second opinion is useful. Those are the kinds of things that we like to do when somebody initially presents with metastatic disease. And then one kind of new thing is that we didn't used to recommend screening brain MRIs because we thought we'll only do them when people get symptoms. But there's a little bit of a shift in that we have drugs that can cross the blood-brain barrier and so-called, and potentially treat cancers that are in the brain when they're smaller and more treatable. So for HER2 positive disease and triple negative disease, in some settings, it may be reasonable to do an initial screening brain MRI when a patient has a diagnosis. It doesn't have to be immediate, but sometime around that time frame, I think can be really helpful. And of course, one of the other things that's really, really helpful is to just talk about what it means to have metastatic disease. And I think that that's a really important part after somebody sort of understands their diagnosis and maybe has a path. It is a really important next step that shouldn't be forgotten.
Absolutely. So it sounds like we definitely have to make sure that we are knowledgeable about standard of care, not consider clinical trials to be only that last effort or that last option. Thinking about your personalized characteristics of your cancer, seeking out those options. And if you are maybe at a community center that isn't, knowledgeable about the latest and greatest, you can still reach out to organizations like ours and then to receive those second opinions and consults that are available. And if it just seems so overwhelming, there are organizations to help you, like the Chrysalis Initiative and MetaViber, where we can guide you and help you seek out what is your specific type of breast cancer, metastatic breast cancer, what characteristics or markers are going on, and how you can seek out those clinical trials, because it's so critical to your outcomes on that continuum of care. So Dr. Newman, I wanted to ask you, based off of your research, when you're seeing the disparities in Black women when it comes to metastatic breast cancer, how does the lack of having access to this type of precision in the diagnostics, in the treatment recommendations, how does that impact or contribute to these disparities that we see in Black women with metastatic breast cancer?
Thanks so much for inviting me to be on this panel. And as a breast surgeon, I'm typically seeing the high majority of my patients at the other end of the spectrum compared to the scenario that Dr. Arugo was very eloquently describing in managing metastatic breast cancer. And as a surgical breast oncologist, I'm often the first clinician and specialist that a patient is seeing after she's been diagnosed with breast cancer. Sometimes I'm the one that's making the diagnosis of breast cancer, depending on exactly how the disease presented. But at these early stages in the continuum of the breast cancer experience, we definitely see disparities with Black women, African American women, tending to have a more difficult time with getting appropriate treatment, completing treatment. And then these issues and disparities that occur at the beginning of the process have consequences along the continuum, and we see them playing out in the setting of metastatic disease as well. When we look simply at the United States burden of breast cancer and the stage distribution of breast cancer for women in the United States, African American women are nearly twice as likely to be diagnosed with breast cancer at stage 4 metastatic disease compared to white women. And then when you talk about patients diagnosed with non-metastatic disease, Black women are more likely to have more advanced breast cancer. We are more likely to have the biologically aggressive cancers, such as the triple negative breast cancers that Dr. Rugo also touched upon. And both of these scenarios, the more advanced stages of disease and the aggressive cancers, are more likely to end up in the metastatic scenario, unfortunately. We are making great strides. Wonderful, wonderful advances have been made in the management of breast cancer so that fewer women will progress onto metastatic disease. And of the women that do have metastatic breast cancer, they are definitely living much longer than in the past, thanks to the wonderful advances that brilliant colleagues like Dr. Rugo have been involved in getting out into the forefront of breast cancer treatment. But for Black women, again, we do see more advanced stages at diagnosis, including metastatic breast cancer. And unfortunately, African American women continue to have issues with the healthcare system, and there are really appalling disparities in the cancer care that is delivered to African American women for a variety of reasons. There are certainly socioeconomic issues that result in Black women having delays in their cancer being diagnosed, their cancer being treated with appropriate multidisciplinary management, and there are disparities in completing all of that treatment. Some of the socioeconomic issues are related to the pure finances and financial toxicity of cancer treatment, since poverty rates and being uninsured or underinsured, those issues are more prevalent in the African American community. These issues are going to have an impact on an African American woman getting her treatment for breast cancer initiated and completed. There are also issues where the lack of diversity in the healthcare workforce will impact negatively on the experience of a Black woman diagnosed with breast cancer. And there are very heartbreaking and sometimes appalling studies that we will read where we see that, very unfortunately, African American women are less likely to be offered opportunities to participate in clinical trials. There are many studies showing that Black women, when they are offered clinical trials, they are very, very enthusiastic and willing to participate. But one of the largest barriers to accruing African American women onto breast cancer clinical trials is the fact that the woman was not offered a clinical trial by her healthcare provider. So there are these issues with inappropriate delivery of care or inadequate delivery of care to African American women. And I strongly believe that we can overcome some of these barriers if we do improve the diversity of the healthcare workforce, and if we have an oncology workforce that's more diverse and that resembles the diversity of the patient population that we care for. So these are just a few of the patterns that I see in practice, predominantly among the women that I'm seeing who are diagnosed with non-metastatic breast cancer. But again, these types of problems are going to be evident across the continuum of the breast cancer treatment experience.
Now, what can, if a person who is of color that has metastatic breast cancer or seeking out care and wants to make sure that they're not vulnerable to these disparities, what are some of the things that we can do system-wide? Of course, having a more diverse oncology team and healthcare system is definitely going to help with that. But how can we also advocate for just more accountability or more integration and standard of care, meaning that people don't have the autonomy to be informed by bias and, end up providing or delivering substandard care unbeknownst to the patient, not aware, going in that vulnerable setting. Is there any way that we can have, more incentivization? What can we learn from like the COVID-19 disparities that we saw initially, and then also the maternal health disparities. Can we apply any of those lessons to metastatic breast cancer?
Well, personally, I think that robust conversations such as this one, these are very, very important. The COVID-19 experience definitely shone a very bright, powerful light on the issue of disparities and systemic racism. People talked in the past about systemic racism, but we didn't acknowledge the broad impact of systemic racism on all aspects of society, including the aspect of public health, until we went through the COVID-19 experience of 2020. And in the midst of that COVID-19 experience, we were witnessing the horrific news events such as the brutal murders of George Floyd, Breonna Taylor, other African Americans at the hands of law enforcement. And these events all coming together at the same time forced us to confront the impact of systemic racism on public health. And now we are very routinely talking about systemic racism in healthcare and how to combat systemic racism. So I am very optimistic that in this moment of time, we are going to make huge strides moving forward in eliminating many healthcare disparities that are related to our inadequate delivery of care. And we are going to be conducting disparities research that is much more powerful than it was in the past. So I think that having the conversation and having everybody be honest about the depth of disparities in the healthcare system and the systemic racism that exists in the healthcare system, that these conversations alone are going to go a long way. They also force all of us who are providers in the healthcare system to be more introspective and examine our own patterns of behavior in terms of implicit biases. They heighten awareness at the patient level regarding the importance of advocating for yourself and interacting with others and seeking support from wonderful networks and support venues such as TCI, such as the breast cancer organizations that advocate for minority women. All of these events, the COVID-19, all of the events that happened in 2020, they were horrible experiences for us to go through, but they did force us to confront some issues that really needed to be tackled.
Absolutely. Now, Shantae, I want to bring you in because I feel like you are, the perfect example of being, an advocate, living with metastatic breast cancer, staying on top of, research, resources, connecting to so many different organizations, but then also making sure that you lean on organizations to seek support. Can you talk about your experience with, being diagnosed, having that delayed diagnosis with metastatic breast cancer, and then how are you navigating now, making sure that you are being monitored, managing your MBC, also educating others, but also tapping into those resources as well?
Yes. Thank you for having me here, and I have a lot to say. I'm a little hoarse, but I hope you get what I'm saying across. So one, I've been living with metastatic breast cancer now for 7 years, and I like to consider myself a privileged patient. I say privileged because one, I'm still alive. Two, I'm still on my first line of treatment. Three, I have sort of access to a medical system that has almost everything. But at the same time, that same system flawed me. It has flaws because I was delayed and denied for 6 years, and from the age of 25, and just was told, no, you're fine. And I am a nurse. I am educated. I am middle class. I have access to care, and somehow it still managed to fail me, because sometimes we like to focus on the low social economic. So if it failed me and I have all those things, think about the people who do not have that, the access, the education, the know-withal to say what they need to have but still get denied and don't even have the knowledge. For a quick example, you know, a lot of people come to me because I have NBC and I know how to vocalize and advocate for myself. I had a friend of mine, of a friend who recently died of metastatic breast cancer, but didn't even know they had it. Why? And they live in the area I live. I live in Washington, D.C. They told them that they died from liver cancer. She had breast cancer that spread and metastasized to the liver, but they categorized it as the death of cause was due to liver cancer. No, that's not true. So this even educating my friend, telling her like, no, you were misinformed. And this is where I am, where I live, and where I am, I have an abundant amount of hospitals and educational facilities and research facilities, but only 2 of them has access to the most greatest and latest information. I was fortunate enough to get what we call accelerated approval through the FDA, through my provider, to get on a medication, and was offered a clinical trial, which again, a privileged patient, which does not happen, which is not common, and was able to get that information and access and be able to provide the imaging. I get imaging every 3 months to kind of track everything. I kind of like make up something because I'm triple positive. I'm not routinely screened for brain mets, even though that can still happen. But I kind of have a headache now and again, you know, just to kind of check myself out, because, you know, standard of care doesn't say that, but we want to change that, right? Just like Dr. Rugo was saying. But I had that access. Being a patient is hard, right? It's not just the treatment I receive. I still practice as a nurse practitioner, but only once a week. But I can't do that as much because my body won't let me. I still do advocacy. I had to kind of reinvent myself. You know, I had to find new joys in my life. And Chrysalis initiative has been very, very impactful for me in these past 8 months because I've been dealing with some crises at home. And I just can't thank about to cry, don't cry. I just can't thank Chrysalis enough. It still continue to this day to help me with all I've been dealing with. I've been assigned like a caseworker, a person. You know, when you just need a person. A lot of us just don't have that person, whether it's family, a provider, anyone. But I've been assigned a person I can literally email, call, ask all the questions I need and get the solutions. They email me so many things of research and resources and financial health, mental health, wellness that I can't even get through them all. So I just kind of mark it and keep it and look at them later. But I have access to the grants and partnerships and webinars. Like Chrysalis is like, and it's not even like inside of my medical system, right? This not being offered where I get treatment. This is something external that is so impactful to me, even with all of my access, that it's been helping me live. Because if I don't have this, and if I didn't have that, I don't know where I would be. You know, stress can equal, you know, progression, which is my greatest fear. And organizations like this just really help magnify the need that society needs this. But people don't know about it. You know, people don't always have access to the internet. They don't have, you know, good bandwidth on their phones. I have family members who get government phones and I can't even do a video chat with them. So how can they get video chat with their provider? You know what I mean? How can they get the information? But organizations like this really help impact it. And then one thing I want to mention, in particular to one of my treatment agents, and which is why it's so important for us to get the proper treatment, the proper imaging, the proper everything, is that, you know, I've noticed on one of my treatments, I have a really, really immunocompromised system. And compared to my white counterparts who are taking the same exact treatment, they're not dealing with or understanding or having to either deal with what I'm dealing with. I'm literally on edge of getting kicked off the medication that's actually working for my tumor because of my low immunity. And I found an article that I might have an innate immune variant through a small clinical trial, small study that could be affecting African Americans on this particular drug. And just having that knowledge and understanding that I have access to that knowledge, everybody don't have that. So it's like, it's just really important that we, focus on getting that information to everyone, that access, the understanding of that information, and increasing eligibility in everything. We should not be kicked out of anything, especially if we want to revolutionize and stop the disparities. Like, it's just, I have more, but no.
Well, no, thank you, because our position is that let's preemptively make sure that women of color who are vulnerable to disparities don't fall through the cracks. So not just that social support, but how can we make sure that all of those aspects of cancer care are being addressed? So the things that, of course, if you're dealing with cancer, you're not thinking about. So just making sure that first off, you're receiving the right treatment, that you are accessing all the latest and greatest innovation to make sure that you are receiving the best care possible specifically for you. Dr. Rigo, I wanted to also ask you about, when a person has progression or when they're initially diagnosed, what about the latest testing available in order to assess treatment recommendations in those hard to biopsy areas? I know that, there's new imaging, new diagnostics. I know you talked about the next gen sequencing, but what about the molecular imaging, which can, like Siriana, that can identify whether or not if it's estrogen driven, in an area where it's hard to biopsy? I know that when I was initially diagnosed, there were some areas in my lung where I, they couldn't biopsy based off of the location. But how are we being better monitored going forward? I know when I was initially diagnosed, the median survival was only 3 years. But thanks to what I learned at ASCO during your presentation, it's just getting better and better. So how can we use this new technology like Siriana in order to make sure that we're staying on top of any progression and keeping that cancer at bay?
It's a great question. And I will say, just based on what we were talking about earlier, my colleagues and Shanti has been discussing, I think that one thing that's really important about this kind of program is that not everybody can listen to the program in the right time. Do you know what I mean? Like, you have to make your decisions right away. So for the people who are on and for the advocates, providing that resource to patients to reduce the fear of getting additional opinions, to reduce the fear of clinical trials, to understand them better. A lot of the fear that's out there still is about the fact that clinical trials are experiments, that, you might not, like, people still think that we are randomizing to placebo, to treat cancer, which we aren't.
Right.
And just understanding the fact that clinical trials in general, and this has been seen in a number of studies, that patients who participate in trials tend to live longer. Now, part of that is because patients who participate in trials generally are in better shape, but not always. I mean, I think it just is having, I tell patients, it's really an idea of having more options. And, your oncologist should always be there for you, and it's a really important point that the oncologist's role is to support you. And so if you don't tolerate a treatment, if the clinical trial doesn't work for you that you're on, it's not like you're stuck doing it. You can drop off and do something different. I mean, that's what's really important, is having the access. You want your provider team also not to be withholding trials for you because they want to keep treating you, because that's how they make their revenue. I mean, sad to say, but true. And they're not going to refer you for trials until you're already exhausted the standard treatments, when clinical trials are, way, way less likely to be available and way, way less likely to work. So, we all have these experiences where we've seen remarkable results from new treatments that aren't approved. So I just want to make that plug. And so for everybody who's on, I mean, you can help other people, and it is our ability to spread that information around, to help people understand, to help reduce fear, that's going to make the biggest difference. And then there's also, for just the incredible disparities in accessibility, there are initiatives now where there is some additional support for a number of different things. I mean, I just met with just today the Pink Ribbon Girls who are in Ohio now and in California, Northern California, and providing transportation and food to patients who have breast cancer so that they can go where they need to go and don't have trouble. And I think it's astonishing still in the United States that we find patients who stop their treatment because they don't have insurance or their share of cost is too high. So we want to use all of these resources. In terms of imaging, your question that I'm not trying to avoid is there's a lot of effort going into trying to do molecular imaging for a few different reasons. So the one you talked about, the Seriana, is to try and understand using a radio-labeled estrogen to see whether or not, if you give that contrast instead of radio-labeled sugar, like we use in a standard PET scan, could you find parts of the cancer that are hormone receptor positive, so you're not poking holes trying to get samples of tumor, which obviously not only is uncomfortable and risky, but also sometimes, like in bone, you might not get the answer that is true. You might not get enough cells. You biopsy the liver, you don't get enough cells, things like that. So could you find out if a tumor is hormone receptor positive? And I think that there are settings where this might be helpful. We had a patient recently who had hormone receptor positive disease, and 3 years later came in with lymph nodes in her neck and also had some disease elsewhere. Now, one of the problems is that Seriana scan doesn't work in the liver because there's a lot of expression of estrogen in the liver. So it can't look at liver mets. It is what it is. But if you have all this bone disease or something in nodes you can't access in the abdomen, you could do that. So they had gotten a fine needle aspiration, just a needle to take some cells. And they said, okay, this is a triple negative cancer. But, she had other sites of disease in bone and node, which seems so hormone receptor positive. And there was just, some cells in the FNA. So we actually did a biopsy of one of the nodes in her neck with one of our ENT and ear, nose, and throat surgeons to be sure. And of course, it was still triple negative. Unfortunately, it's bizarre. So then we wanted to find out what the bone disease was. So we did get an FES PET, but what's interesting, that's what's it called. It's having this labeled estrogen. E is estrogen, S PET. But the problem is that the insurance denied it, and the insurance denied it on appeal. So their feeling is if you have a biopsy, it's negative, it's negative. But we wanted to get an idea of what was going on. The FES PET actually, interestingly, which she chose to go forward with, was negative in the other sites of her disease. So I think in some situations, it can give you some confidence. It doesn't tell you if your cancer will respond to hormone therapy. So that's the problem. Like, you could know there's some expression of hormone receptors, but doesn't tell you what treatment will work. So there's another area of investigation with imaging where we're looking at radionuclides. These are all what's used, where they might look at a specific receptor, right? And you have a targeted agent that targets that receptor. So you could tell if it worked. Now, lots of investigations, nothing ready for prime time. It actually turns out to be really difficult because the expression of a particular target might vary a lot. The imaging radionuclides or the material that's used to find the target is maybe not as sensitive as it might be. So it's a really intriguing area that I think is of great interest, but other than FES PET, it's not ready for prime time. And we don't follow cancers with the Seriana FES PET scan right now. And again, it can be hard to get insurance approval. Now, Seriana itself will help with insurance issues if you run into them, and it's felt to be a really important diagnostic test for you. They offered to help with this patient, and that's still going on. So that's another place to reach out to, is to ask your center for that representative to contact. But again, I think it's important to keep in mind that these new imaging tests don't tell us what's going to work for treatment.
Gotcha. Also, and I'm not sure if this is a fair question, but I know that with metastatic breast cancer, the cancer cells can be, filled with tons of mutations and very heterogeneous. So how do you determine best practices? What is the best driver or best target to go for? If you are having a patient that is now on multiple lines of treatment, drug resistance, constant progression, what are some of the tactics that are now being incorporated so that you can really identify what could potentially have the most, which treatment would provide the most durable response?
Yeah, I wish we had an answer for that, and we just don't. These acquired mutations, we're trying to get around estrogen receptor mutations with new endocrine therapies, mutations in what's called the PI3 kinase pathway, and the immune marker that I mentioned earlier. But all the rest of the studies that we've been doing, targeting different mutations so far haven't resulted in tolerable treatments with good responses. So it's just, for example, we've been trying to target something called the fibroblast growth factor receptor for a long time. And, the first set of drugs just had way too much toxicity. And then now this next set of drugs, we haven't, I think we might be on the verge of finding better drugs. We're trying to target the androgen receptor, this part of the PI3 kinase pathway. We have a new drug from a press release that seems to have effectiveness called capivasertib that will be presented at the San Antonio meetings in December. And then the new endocrine therapies. But I wish we had better treatments. You can look at all these targets, and there was a program, I won't mention where, somewhere in California, where this group had, their sort of precision medicine. And, everybody wants precision medicine. It's like, oh, you're going to treat my cancer, right? So I consulted on a few patients who've been there, and they went through their mutational profile, and then they picked out drugs that were approved for other cancers that would target the mutations they had. And sometimes they mixed them together. And so it's referred to as an N of one, like you study the treatment in one patient, but they didn't provide any financing for the drug. So what ends up happening is the patients went there, they felt like this was their only lifeline in a combination that had no data at all and had potential toxicities that weren't known. And then they were going to spend their life savings buying these targeted drugs. So I think we do have to be careful about sort of throwing things in based on mutations where we have no idea that they're going to work and they have a lot of potential toxicities. You don't want to be complacent, but you also want to balance the risk versus benefit of any one treatment that you're going to be looking at. And you want to talk to people. And, phase 1 studies are first in human, right? And there's a reason why breast cancer patients are very poorly represented in first in human studies. And that's because we have a lot of treatment options for the majority of breast cancer patients with metastatic disease that are effective. And now we have treatment options for every subset that improves survival. That doesn't mean that it prevents you from dying of cancer, unfortunately. So we still want to be seeking all of these new treatments, but we also want to be cautious about using treatments that, again, may increase toxicity and don't have any proven benefit. Trials are important, but we also have to pick and choose. So, Lisa, you had your hand up earlier.
My oncologist told me the same thing.
Thanks, Hope. I just wanted to build upon your comments about clinical trials and using forums like this to get people to be ambassadors to the general population of cancer patients regarding participation in clinical trials. And I wanted to stress the message that for those who are reluctant to participate in clinical research because of mistrust of the healthcare system or fears related to knowing about past abuses in the research system. It's true, there were some pretty horrific abuses in medical research in the past, but today, being part of a clinical trial is actually a huge protection against being subject to receiving disparate or inappropriate care. The whole clinical trials mechanism is so tightly regulated, and everything is specified and monitored, from the stage of disease, the type of disease, the treatment delivered, the monitoring and follow-up afterwards. It's a huge protection for the patient, for the participant, against receiving inappropriate care.
And I would just say that I know it can be overwhelming and intimidating. What do you recommend? And this is a question to both of you or anybody. Shantae, you can also chime in if you like. I know that I participated in clinical trials, but how do patients know what is the best clinical trial for them? How can they vet the information that's being shared with them?
I think it is really hard. I think that at every step of the way, when you're making a decision about treatment, you want to ask your treating physician, are there any trials for me? You can actually go onto NCI, the National Cancer Institute's website for the patient-facing part, and search engines like breastcancertrials.org, and put in your cancer and sort of see what exists. Bring that information back to your treating team. And mostly we have electronic health records now. You can send that information in advance of your visit. And I always tell patients, send what you're interested in before you come and see us if you possibly can, because, you got these visits, I'm an hour and a half behind, I never want to make a patient feel rushed, but
Mm.
I think we do a better job of exploring a lot of these things if we have a little bit of heads up notice to look at a specific trial that a patient might be interested in. Some people will say, like, for example, a trial will be available in Texas and they have a relative there, so they could go stay there and they want to go do that. Other situations that may not be the case, or, for whatever reason. But I think you should always be able to have a connection with your team where you can ask about any trials that are available, and you don't want to wait until you've had lots of prior treatments. If that's just one piece of information we can convey, you really want to look at these novel agents much earlier, even in the very first line. And I think that, getting second opinions helps a lot too. So, you go to the academic center that's nearest to you and you get a second opinion about what treatment options are available to you. It doesn't mean you have to do your treatment there, but at least you know what's available. We all do those consults all the time. And it really does help a lot. As soon as you find out you're in a situation where you have to make a treatment decision, you want to, get that second opinion and find out what other options exist for you. There are even now online services. Unfortunately, you have to pay for them, which is a little complicated, but some offer assistance as well, where you can actually do an online second opinion and get information about your disease. So there's so many different ways that you can get this information. Somebody had asked about complementary treatments, and just to mention about that is that complementary treatment are treatments that complement the therapy that we're giving. And there are lots and lots of treatments that can be very helpful for patients. For example, acupuncture, acupressure, yoga, mind-body treatments. There are really, there are projects in music therapy and meditation, and even, projects that capitalize on people's belonging, or organizations that they belong to of a religious nature as well. So it just depends on who you are and where that organization is for you. And there's just a lot of different options for complementary therapies, which help our patients and help with management of a whole host of different symptoms that patients have.
Absolutely. So I am just so joyous about this panel this evening. I hope that we have helped a lot of folks and improved everyone's knowledge, and, make people feel more empowered to reach out and seek out that support in order to all of the above, getting the right treatment, getting assistance in processing all of this various information, tapping into clinical trials, tapping into those integrative therapies, preemptively thought partnering and having that support to make sure that you have everything that you need in order to stay on track and not be vulnerable to disparities. So I thank everyone for joining. I thank Dr. Newman and Dr. Rugo with your busy schedules for fitting us in this evening. And Shante, thank you so much. I love you. And thank you everyone for joining.
Thank you.
Thanks.
Thank you.
Have a great evening.
You
Take
too.
care.